discuss regarding the optimal selection of RAS blockers in patients post-MI. So with that context, I would like to invite our expert faculty here. We have Dr. Ambukeshwar Singh, sir, is going to moderate today's session. Of course, he doesn't require any introductions. Sir is a DM cardiology and the associate director and unit head of interventional cardiology at Max Hospital, Lucknow. We welcome you here, sir, today. With that, we also have Dr. Suvendu Chattopadhyay from West Bengal. We have Dr. Shamshad Alam, who's the Associate Director of Cardiology Department at Medanta Hospital, Patna. And finally, Dr. Deepak Basia as well, who's the Head of Department of Cardiology at Meerut. So with this, over to you, Dr. Singh, to take the discussion ahead on optimal selection of RAS blockers in the post-MI patients.
Thank you, Dr. Ronak. I welcome all our panelists, all who have joined this session, and especially Dr. Deepak, Dr. Shivendu, Dr. Nosad. So basically, I think it is the best time to revise the trials which has been done for the RAS inhibition in case of MI, although all are expert, but many times when we revise, it is good to revise the trials. Next. So as we know, there are three types of RAS inhibition. One is by ACE inhibitor. Second is ARB, that is the receptor blocker. And third is newer is the ARNI. There are three types of molecules available today for inhibition of RAS. So basically, we will discuss the flow of this discussion will be, first I will discuss the trials which has been done for these molecules. And then we will discuss, we'll try to take the view of our expert panelist. Next, please. So first of all, what are the trials for the ARBs in post-MI cases? So we have two main trials. One is the optimal trial and second is the valiant trial. Next. So in optimal trial, which are done in 2002, that shows the we compare the losartan with the captopril, and that showed that a non-significant difference in total mortality, and this was favoring the captopril, although non-significant, but numerically the mortality was less with the captopril. ACE inhibition should be remain the first choice treatment in the patient after the acute MI complicated by heart failure. And losartan can be generally cannot be generalized recommended in this type of population. So that is the result of optimal trial. Next. In valiant trial, which compared the valsartan in the acute MI, so mortality from the all cause and the cause specific mortality were similar in the all three groups. The groups were the three. So in all three groups, the mortality was same. There's no difference significantly. The rate of secondary endpoint of death from the CV causes, recurrent myocardial infarction, or the hospitalization for the heart failure was similar in all three groups. So basically, all these two trials, valiant and this trial, doesn't show any benefit in compared to ACE inhibitor. Next. So next, coming to the ARNI. So let's see what is the trial for the ARNI. So that was we know the Paradise MI trial. Next. In this trial, acute MI, the patient was randomized from between the same day to up to the 1 week with the EF less than 40% and the symptoms of pulmonary signs of pulmonary congestion, plus any other risk like the age more than 70 years, EGFR less than 60, diabetes, any prior MI, the presence of atrial fibrillation, EFR more than 30%, CLIP plus 3, or STEMI without reperfusion. And the patient with the prior heart failure, clinical instability, and EGFR less than 30 were excluded from this trial. There are two arms. One arm is the secubitril valsartan, that is the ARNI, 200 milligrams twice a day. And next was ramipril, that is the 5 milligram twice a day. This was the double-blind active control trial. And what was the result? The primary outcome was severe death, and the first heart failure hospitalization or the outpatient heart failure were non-significantly between the two groups. We can say there's a numerically less events in the ARNI group, but that was non-significant. Next. So we can see in the all events, either primary outcome or secondary outcome or severe death, hospitalization, outpatient heart failure, it was not superior in compared to ramipril, and both it was the non-significant. Next. If we see the adverse event, the hypotension was more in with the ARNI in compared to ACE inhibitor. Cough was almost the same. The most two common adverse event, one is the hypotension, and second is the cough. Hypotension was more significant in the ARNI group in compared to ramipril. Next. So we can summarize this secubitril valsartan did not result in a significantly lower rate of CV death, heart failure, hospitalization, or outpatient heart failure requiring treatment. The pre-specified observations of the reduction in both the investigator reports of the primary composite as well as the total educated events support incremental clinical benefit of secubitril valsartan. So there is some benefit, but it was not significant. The safety and tolerability of secubitril valsartan in this acute MI group was comparable to that of ACE inhibitor. So we can say with the help of ARNI, there's no extra advantage, there's no added significant advantage in compared to ACE inhibitor. Next. So after this Paradise MI trials, there are many reports like this molecule can't beat the ramipril in the acute MI patients. So this type of opinion was given in the different journals. So we can say with this trial, doesn't support the use of ARNI over and over the ACE inhibitor. Next. Now, the third molecule, that is the ACE inhibitor. Let's see, because we know this is the oldest molecules and there are many trials on the ACE inhibitor. So let's see, because only on the basis of these trials for the ACE inhibitor, this group of molecules came into light for the use of these molecules in the post-MI patient. For the major trials like the SAFE trials, IR trials, TRACE, there's some short-term like the consensus, GC, and ISIS-4. All these are trials for the ACE inhibitor in the post-MI patients. Next. So let's discuss briefly for the all these main trial, like the SAFE trial. It was the randomized, double-blind, placebo-controlled trials setting in the MI with less than 40% EF. These are randomized between the 3 to 16 days. The drug was captopril, maximum 50 milligram TDS versus placebo, and the follow-up was up to the 36th month. What is the result? The captopril group showed 19% reduction in mortality and 25% reduction in the recurrent MI. So this was significant. The p-value was, we can see that 0.001. So this trial showed the importance of ACE inhibitor, this is the molecule captopril, in case of acute MI, in acute MI. Next, SAFE trial. Next, please. Second was the TRACE trial, the randomized, double-blind, placebo-controlled, multi-center trial. This the patient's criteria was acute MI with the randomized between the 3 to 7 days. The drug was trendopril. The dose was maximum 4 milligram versus placebo. Follow for the 24 to 50 months, and the result was again in the same, like the 25% reduction in the mortality, 15% in the recurrent MI, and 20% reduction in the sudden cardiac death. So, as with the captopril in the previous trial, the TRACE trial also showed the the benefit of this ACE inhibitor molecule. Next. Some other trials like the ACEs, GCs, and GCS1, all we can say showed the same type of benefit, more or less, because ultimately this is the class effect. Next. This is the IR trial. This is a double-blind, randomized, double-blind, placebo-controlled trial. The patients were acute MI with transient or persistent heart failure. They randomized between the 3 to 10 days. The drug was Ramipril. The follow-up for the 15 months, and the result was same in the line of same, like the 27% reduction in the mortality, 19% in the rate of MI and stroke at 6 months. And we can say the p-value was very significant, 0.002. Next. In the same trial, when it was extended study, we showed the patient was followed up to 42 to 59 months. And the importance is the beneficial effect of Ramipril started early after the MI with heart failure and are sustained over the 3 to 5 years despite the discontinuation of medication at 1 year. We can say that is the legacy effect. And the treatment of 9 patients with Ramipril for an average 1 year will result in the 1 additional survival for the 5 survival to the 5 years. So this is the very important statement. With the help of these molecules, ultimately we are expanding our the patient survival. Next. Then again, there is some very long-term benefit of this molecule in the very extensive, very extended trial of the same trial as study. The patient were follow up to 30 years. Next. And the result showed the median survival time was 8.3 years, placebo group, and 9.6 year with the Ramipril group. So ultimately 14.5 months incremental survival in case of this Ramipril group. The survival curves across the 14 years from the time of randomization, and the life expectancy was greatest at about 15 years. And the life expectancy was improved with the Ramipril across all the comorbid groups, which we'll see in the next slide. So in this slide, we see in compared to if you see the life expectancy between the placebo and the Ramipril group, it was increased in every other comorbid condition like diabetes, previous MI, history of hypertension, and all. Ultimately, the life expectancy was more in with the use of Ramipril group. Next. So there are substantial survival gains with the Ramipril treatment for the 15 years beyond the blinded treatment allocation. The overall, we can say that for every day of patient received Ramipril, an average his or her life is extended by 1 day more, and the relative risk of survival for the patient with diabetes was increased by 54%. Next. The patient with diabetes, previous MI, previous heart failure, hypertension, and angina, each group of patients were benefited and on an average from the ACE inhibitor, use of ACE inhibition. The treatment with the Ramipril for about 1 year when it started early in the post-MI in patients with heart failure that result in the survival benefit, which is of life for additional 1 year. Next. So treatment with the Ramipril for about 1 year when it started early in the post-MI in patients with heart failure result in the survival benefit, which is sustained over many years and offers and on an average additional 1 year life expectancy. Next. So on the basis of all these 3 groups of trials, we can conclude for the ARBs, no superiority over the ACE inhibitor. For the ARNI, no superiority over the ACE inhibitor. And only the ACE inhibitor groups of the molecules showed significant difference in compared to placebo if you talk about the mortality and different MI. So we can conclude that ACE inhibitor must be given in in each and every patient of post-MI if indicated on the basis of heart failure and all. Next. So what are, we can say now, what are the recommendation after acute MI? First drug we should be start, that is as early as possible, that is the ACE inhibition. Beta blocker, as you know, should start later somehow after 24 hours, because initially there is the if you start beta blocker initially in the 24 hour, we can aggravate the heart failure. Then the next very important drug is the MRH. That should be start within 7 days. There are trials which showed if you start the later, the benefit is less. If you start earlier, the benefit is more. And in between, after ACE inhibitor and MRH, we should try to start beta blocker if there is no contraindication. And it is critical to titrate doses of medications at the time of discharge and after post-discharge with the judicious follow-up. What about the ACE inhibitor? This should be administered within the first 24 hours for the heart failure patient with the EF less than 45% in case of acute MI. Next. If we talk about the guidelines, about 2020 ESC guidelines for the treatment of acute MI patients without the persistent treatment elevation. So ACE inhibition, that is in ACE inhibitor, ARB in case of intolerance to ACE inhibitor. So this is very important. We should try to start with ACE inhibitor. If patient can't tolerate or any adverse event, then of course we can start with the ARBs, but the first choice should be ACE inhibitor, and that are recommended in patients with the heart failure with reduced EF unless there is any contraindications. Next. So 2025 guidelines released in February 2025, the ACCHA. So just let's see. Class 1 indication for the ACE inhibitor in high-risk patient, that is with ACS, that is EF less than 40%, hypertension, diabetes mellitus, or STEMI with anterior location, and oral angiotensin ACE inhibitor or ARBs is indicated to reduce the all-cause death or the major adverse event. So this drug, the class 1 indication, and in patient with the ACS with the EF less than 40% with the heart failure symptoms and the diabetes mellitus should be given MRH also in the early course of the disease. So post-MI patient, reduced EF, there are two drugs which should be given always as early as possible. One is the ACE inhibitor and second is the MRA. Next. So this was a brief, we can say, introduction to all these trials. Now this we will move forward to our main discussion portion. So I would like to invite all our panelists. Dr. Samsad is there?
Yes, yes.
Dr. Samsad, Dr. Shivendu, and Dr.
Yes.
Deepak. So let's discuss.
Yes.
We'd like to know their comments and experience. So Dr. Samsad.
Yes, am I audible?
Yeah. So as we discussed, we should start the ACE inhibitor. So you'd like to see the BP. At least you are comfortable at which level that, yeah, I should start at this level.
Yeah, just in a case of acute MI, the comfortable BP for me, it should be above 100. Systolic blood pressure, it should be 100. But yes, above 90, if my patient is maintaining above 90 and still if the patient is having severe LV dysfunction, then still I prefer to start with a very low dose, 1.5 milligram of ramipril. Still I prefer, because I know my patient needs this, because we have to stop that positive remodeling as early as possible.
Fair enough. Those basically we should start. We should try to start maybe in very little doses, no doubt, because it is beneficial even in small doses. Then how you titrate in your practice?
Yeah, as per the literature says that the Ramipril dose which we give. In India, the usual dose requirement is less as compared to the Western population. In Western population, the dose in 1.25 to 5 milligram is almost never used, what we use in India. So they say that any dose of Ramipril below 2.5, it is not having to go with that much of benefit. So my target is to achieve that minimum dose of 2.5 milligram a day. And if possible, I can titrate it to 5 milligram to 10 milligram a day. So the titration is not an issue. What with ARNI, they say that you titrate it every 2 weeks. But if my blood pressure, if my patient is maintaining blood pressure of 100 or between 90 and 100 at a dose of 1.25 and he is comfortable, his renal functions are good, then I take an attempt to increase it to 2.5 if he can tolerate with that blood pressure. If his blood pressure is above 100, then obviously I increase the dose. The duration, I do not need to up titrate the dose if my renal functions are good.
Yeah, sure. So, is there Dr. Swendu there?
Yes.
Yeah. So I think there's a one more interesting scenario. Suppose a patient is taking ARBs before for the just like hypertension, and now he developed the interval MI. You manage the patient. So we'd like to switch from ARB to ACE emitter after MI.
Well, the question looks simple, but the scenario is not so simple.
Yeah. Sure.
Before MI, patient was in a stable condition, a hypertensive patient who is taking ARB. Now after MI, the lots of things are changed. So in after MI, whatever will be the pre-MI blood pressure, patient may go into a cardiogenic shock. Patient may land into a hypotension. So we have to think about an in MI situation. So we use lot of nitrate. If even the BP is more, we use nitrate to reduce the chest pain. So after that, when the patient is stabilized, we have to look for the ejection fraction. So what is the risk of the patient? Now, according to guideline, if the ejection fraction is less than 40%, so within 24 hours, we have to start ACE inhibitor, or guideline says or ARB only when patient is intolerant to ACE inhibitor. So obviously their ACE inhibitor is the first choice. So definitely I will start ACE inhibitor in those category patient, and I will titrate the dose accordingly what Dr. Samsed had just said.
Yes. Yes. So I think everyone agreed with you. So we should try. Many times we hesitate to switch. As you said, this is the common question, but definitely because many times we see a patient is already taking telmisartan, why should switch to the ACE emitter and all. But you said very well, we should try to switch to the ACE emitter because the trials are in the favor of ACE emitter in compared to ARBs. Okay. Next, Dr. Deepak. Dr. Deepak is there?
Yes. Hello, sir.
Hi. So we know for the acute heart, if we talk about the heart failure, ARNI is over above the ACE emitter. There's no doubt. No. But if you talk about the post-MI heart failure, how we see the ARNI?
So first of all, sir, you wonderfully summarized the journey of RAS inhibitors. And as far as you told, the ACE inhibitor is the preferred choice in post-MI patients. So in which in the Paradise MI trial, the ARNI is given to the patients of MI, and before this study, only ARNI is studied in heart failure patients. Yes, you already told about that, and where the specific patient subset of the post MI not defined. So as per my experience also, the ARNI should be initiated within 24 hours of the post MI with LV dysfunction. But before this, after seeing this, the patient should not be clinically unstable. And like patient on IV diuretics or vasopressor and systolic blood pressure less than 100 in ACE inhibitor or ARB patients, or pressures less than 110 in NAVE patient in past 24 hours.
I think it is a very important because practically we are in the favor of ARNI. I think no doubt. In the heart failure, any heart failure, we are in the favor of ARNI. So I would like to comment of others panelists also, Dr. Samsad and Dr. Swendu. What are your opinion beyond, apart from this trial? What is the critical? What do you think?
Actually, this is a thing which has to be discussed. So heart failure post MI, one heart failure which is occurring just after MI in acute situation, and one heart failure is there which is occurring 3 months after acute MI event. So these are two different subsets. In those subsets who are beyond 3 months, then obviously in that cases I will switch on to ARNI in place of ACE inhibitor. But these acute cases, because to me the data is not that much robust. So in these patients, I will still prefer ACE inhibitor to ARNI in acute MI situation, heart failure.
Yeah. And at least in paradigm MI trial, that was non-inferior. We can say it is a non-significantly superior to the this estimate. But ultimately, it was not inferior. If there is any extra events, extra side effect.
Now, in Paradise MI trial, actually, we see that there is no statistical significant difference, but numerically still the data support ARNI. So numerically, there is some benefit more with ARNI, but still, as our conventional practice in acute MI situation, we conventionally use AC inhibitor only. After that, when the patient is stabilized, suppose after weeks or after month, then it is our common practice nowadays to switch over to ARNI.
Sure. So next, again, if after we did the patient with the MI, we did the angioplasty and all, and if we find this, there's a EF is still EF is less than 40%, but without any sign and symptom of heart failure. So now, what do you prefer?
So the thing is that any LV ejection fraction less than 40%, it is a labeled heart failure with reduced ejection fraction. I do not need clinical signs or anti-proBNP levels because I have got LVEF less than 40%. So it is a class 1 indication. It is not necessary that you have to have symptoms to start ACE inhibitor or ARNI. So these patients have to be started on ACE inhibitor if it is acute STEMI situation. And if it is a delayed STEMI situation, 6 weeks or 12 weeks, then obviously ARNI will be my drug of choice.
So good. Basically, no doubt, ARNI is better, but because of in early post-MI cases, we can say there's a higher mortality and all. I think even we don't expect many difference now between the two drugs. Because in post-MI cases, heart failure, there is a higher mortality in both, even certainly more. So good, we can start with the estimator, but later we can switch to the ARNI.
Yes.
So if same setting, if the post-MI patient was already we did the angioplasty and all, what are the timing for the starting beta blocker? If before the ACE inhibitor or after the ACE inhibitor? Dr. Deepak.
Yes, sir.
Dr. Deepak is there?
Yes, sir. So I would prefer
what to do?
I would prefer as early as possible. I want to give beta blocker. If patient is not in decompensated heart failure, I would start early beta blocker.
Yeah, Samsad?
Yeah, see, if my patient is free from chest pain, angiographic revascularization has been done, or if I haven't performed angiogram to this patient, so I will plan to start beta blocker as early if patient is not in decompensated heart failure. Second thing, if my patient is of infeval MI, and if any event of bradycardia or if heart rate is 50 or borderline or 50 between 50 and 60, then I will obviously avoid beta blocker in initial 24 hours. I will see how is the trend of the heart rate and how is the trend of the QRS duration in patient of especially of entry volume MI. Because the QRS duration gradually in few patients it maximizes. At times, patients of interval MI, they turn into PRBB pattern in next 24 hours. So these things has to be monitored. So I will not be in a hurry to start beta blocker as early as possible. Still, I will try to wait for 12 hours to 24 hours. But if the patient is having chest pain, then obviously I will give injectable in spite of oral to these persons.
So we can say in the best scenario, if the BP allowed, if the heart rate allowed, if QRS is not provided, we can start both drugs as early as possible, provided the each and every conditions we should monitor and the pulse, BP and all. I think everybody is agree with this.
Yes.
So any specific beta blocker people like to choose?
Yeah. Metoprolol, short acting,
Yeah.
just post MI.
Okay.
Yeah, I agree.
Next. Yeah. So I think we have one more thing we know nowadays is we talk about we are very talking about the NT-proBNP. Dr. Deepak, would you like to see the level of NT-proBNP to decide which molecule should we start, ACE-inhibitor or ARB, ACE-inhibitor or ARNI?
Sir, as you know, as we know, the another landmark study, the paradigm HF, shows that the ARNI is more significant decrease the anti-pro-BNP compared to ACE inhibitors, and the greater reduction correlated with better outcome. So, in my experience, I used to give ARNI over ACE inhibitor in this scenario where the anti-pro-BNP values are very high, like 9,000, 10,000. And yes, if the pressures allow and there is no absolute contraindication to this.
Yeah, so Dr. Shivandu, any comment on this?
No, same. I think what Dr. Deepak has told, my opinion is also same.
But in the post-MI cases, yes, Dr. Samsad.
In post-MI patient, actually, see if a patient already in heart failure, then NT-proBNP level definitely it will be high. So I don't think based on NT-proBNP now it is to be decided whether I will go for a SC inhibitor or ARB. It is months or weeks after when the patient stabilize, then only we can consider, because even nowadays in heart failure with reduced ejection fraction patient, we don't consider doing NT-proBNP. We reserve it for heart failure with preserved ejection fraction patient when we cannot diagnose the heart failure if we are not having NT-proBNP report. If the ejection fraction is less, definitely the patient is in heart failure.
Yeah, Dr. Samsad.
Yeah, what I said that only the situation is the deciding factor. That whether it is a post-MI situation or it is a chronic heart failure post-MI, then it is to be decided whether we have to start with ARNI or amipril. Anti-proBNP level, for me, it is nowhere mentioned. Any guideline never suggests that anti-proBNP is a deciding factor to choose between ARNI or amipril. It's the patient's scenario.
Yes. So apart from this topic, what I think the importance of NT-proBNP, what is my opinion, especially like in such a scenario, a patient is already taking ARNI 100 milligram twice a day, is stable and all, and we want to increase his doses. If I think he is clinically well, but NT-proBNP level is high, so this is we can say the drive factor to increase the dose of ARNI. Anybody on this? Any comment on this?
Oh, I have one opinion. So actually, whatever will be the NT-proBNP, the guideline says if we can up titrate the dose of ARNI, that is the target dose is 200 milligram BD, we have to up titrate. Even patient is stable, even the NT-proBNP level is normal, but still when there is a scope of improvisation, we have to improve.
Just I said that this is some practical things. It just is driving force. Yeah, it is stable, but because NT level high, we can go more high level. You know, you're right. It is the guideline said, but many times we have up to 100 we are okay, but 100 to 200 many times we very frightened about the BP and all.
Yeah, actually, whenever I use ARNI, two things I see. One is improvement in ejection fraction. If my patient is symptomatically well, I have achieved up till 100 milligram twice daily, and his ejection fraction it has reached 50%. Then obviously I'm not going to benefit that much on further increasing the dose. Yes, but if usually we do not prefer getting antiproBNP done in these asymptomatic patients. But anyhow, if somebody gets it done and we find that it is significantly raised, it is above 1,000 on still that medication, then there is a scope of increasing the dose or adding on other medication if it is still to be added.
Yeah. So I think it is not the guideline, but practically we are doing, we can say as many times, it is at least if level is high, so we can think about the more drugs and all. Okay, I think they're a good discussion. And so if Dr. Samsad, suppose you did the angioplasty after anti-LMI, but after a few days, after a second day, you do the echo, and EF is not less than 40%. EF is quite, because you did the primary angioplasty in within 6 hours. So, but EF is good. So, what do you think? You will start
So,
estimeter or not?
See, once a patient has come to me with primary interval MI, ejection fraction of 35% in presentation. I did primary angioplasty next day or just after 2 days, the ejection fraction went up to 45%. Still, I will give ACE inhibitor in these patients because this is the time when I have to. This is the time when I have to stop any kind of positive remodeling if it is going to happen.
So suppose EF is not, EF is good, EF is 50%. Patient EF was already 50%. You did the angioplasty within a few hours, and EF is not decreases. EF was more than 40%. But I think we should start. We should start because it is not just EF.
I start because when I take the patient for primary angioplasty, at that time, if ejection fraction, I think it is 40%, but anyhow, it has increased up till 55%, especially in those primaries with circumflex or RCS. But still, I started at the index time and just after primary angioplasty. If the pressure is good, I start with ACE inhibitor.
Yes, because EF is very observational thing, but ultimately the pathophysiology is same for EF less than 35%, EF 42%. There's the RAS inhibition. So we should try to give, especially I think post anti-LMI. In every case of anti-LMI, I would like to, no matter EF is what, I would like to add
that is for
RAS
sure.
inhibition.
And it is very surprising if somebody says that EF with anti-LMI, it has increased to 50% just after primary angioplasty next day. It is very rare for us because our patients usually never present within 1 hour of anti-LMI. Anything which crosses beyond 1 hour, it is obviously going to impact on myocardial function.
Dr. Deepak?
Yes, sir. I'm here.
Any comment on this?
Sir, yes, I'm agreed with that. The ACE should be given in every post-MI insult patient if the pressure allows.
Sure.
If insult is happened, then everyone should give the RAS inhibition.
Sure. Dr. Shivendu, what do you think in your practice, what percent of your patients tolerate ARNI 200 milligram twice a day versus Zamipral 5 milligram twice a day?
Well, in paradigm heart failure data, they have given 76% patient tolerated ARNI to 200 milligram twice a day. I don't know where are this population, but in my clinical practice, it is less than 50% patient, hardly 30 to 40% patient. That too in the stable heart failure patient, not post-MI patient. Post-MI patient, as we have already discussed, that we prefer ACE inhibitor, not ARNI. So in heart failure patient, in my clinical practice, I get 30 to 40% patient where I have titrated the dose up to 200 milligram twice daily. And in Ramipril patient, it is mostly in my practice in post-heart MI patient, not in the stable heart failure patient or the heart failure follow-up patient scenario. In post-MI patient, actually, I have never given or I am able to give 5 milligram BD dose in those patients.
Very nice. No doubt.
5
In every
milligram is 0.5 milligram twice daily is the maximum for me, initial stage.
Absolutely agree with you. Even I can say practically in my practice, if out of 10, only 1 or 2, 3% are taking 200 milligram. And in every, just like CME, I used to talk, ask this question to everyone. So hardly 20-30% of our patients in our population are taking 200 twice a day. Dr. Sansad, what do you think?
Yeah, actually, 20% is also a high number.
Yeah,
Whatever I have seen, even
definitely.
other patients also, those who were consulting other cardiologists, the number is less than 10%, practically at times less than 5%, I can say.
Very less.
That's
Because if I have 50, once a time, once in OPD, 10% of my heart failure, hardly 1 or 2% are taking 200 milligram. Otherwise,
Ramipril
mostly 50
500,
milligram.
yeah, Ramipril 5 milligram BD. What I have seen that those patients who live in UK and they have come for holidays in India, or those patients who live in US and they come for holidays in India, when they get a consultation, then we go to see that some patient is taking 5 milligram twice a day, 10 milligram dose. But in India, it is very rare that patient are needing that much. Actually, it's our body kind that we are not tolerating that dose.
How many of you start half doses, 50 gram half doses? Is your practice? Although it is not recommended, no doubt, but just
Yes,
practically,
it is not recommended, but still we are using.
We are using.
Yeah.
Because many heart failure patient and mostly Indian women, young women with a DCM, these patients have a baseline BP is 90/60. So in those patients, either we are unable to start ARNI or that's 50 milligram half BD.
Well, honestly speaking, after 2 to 3 years back, I was against this, but definitely I am very agree with this. Last 2 to 3 years, I have been using this drug twice a day. Definitely, it will improve the even a BP improved. EF problem. This is a good drug. So we should try to start even a half dose, 50
At
gram
least
half
safe,
dose.
safe BS,
Some
sir.
patient take 1/4 also twice a
It's
day.
safe, especially patient entered the acute LVF. We stabilize the patient. We have to discharge. We know, especially in corporate sector, patient is pocket is very high. So next day patient want to discharge. Today is admitted, discharge third day. How can we start? So our practice start very low dose, 50 gram half a day,
Yes.
twice a day.
Initially, I used to give 50 mg BD, and then patient land up in the hypertension. So after that, I usually started with the 50 mg half BD, and patient tolerating good.
So means
And
I am right. Well, many are treating this, not only me, many of you. Good.
the 50
Boss,
mg
Good to
half
see you.
BD
you will
and
be
the
surprised
maximum
that
dose 100 mg BD. I usually, matlab.
No, for those patients
some
whom
people
we
have
are
prescribed
giving,
even 1/4 twice daily dose.
No.
in
Few days back, we in the CME, the actually notice people are saying they are in for Indian population, they are coming with the 25 milligrams pill. They are planning to 25 milligram.
no, few company now scored the 50 milligram tablet is also scored nowadays in few companies. So actually, whom we are giving 50 milligram half BD, definitely they are having some improvement after weeks when they are coming back. So at least symptomatically they are improved, but I don't know, or I cannot say it is because of ARNI. It may be because of a combined effect of, because I practically give in those patients the 50 milligram half BD with ivabradine if patient in sinus rhythm and SGLT2 inhibitor. So maybe because of the combined effect and very low dose diuretic, if possible.
Yeah, sure. So what is the frequency of hypotension in such patients?
Oh, many patients came like Indian young female with a basic when patient come back, symptomatically they are very well, but the BP is 80/50. Now the patient who is doing very well with 80/50 BP, I should continue the dose. But the patient, few patients are there who are complaining of the postural hypotension symptom like this. So in many patients are there, I had to stop ARNI and continue others.
So what I think, numerical BP is not important. As I said, the symptoms are important because many
Yes.
times Patient doing very well, no symptoms, and the only complaint of patient is जब मैं BP नापता हूँ, BP is 76. There's no complaint. So I used to say, BP मत नापा करो. If you don't have symptoms, don't go for BP, because such patient have BP 88, 84, and then they are worried. रात में phone आ गया, मेरा BP is 84 है. Complain, no complaint. So I think numerical BP is not very important. We should explain about the symptoms of heart low BP for the patient. That is more important. What do you think, Dr. Samsad?
Actually, auto-regulation is the thing which is working. Our CKD patient, they tolerate a blood pressure of 180, 190 so normally. But in a normal patient, if he gets a blood pressure of 180, 190, 200, he gets headache. But CKD patients, they are used to it. A similar thing is occurring with these patients of heart failure who have, for them, a blood pressure, systolic blood pressure of 80, it is auto-regulated now. 80 is just like a normal for them. Renal perfusion is well maintained, then we need not to worry for anything.
But in such patient, would like to increment the dose. Suppose patient
No,
BP is 88, but no symptoms, no symptom hypertension.
So
I think no.
basically, for increasing that numerical value has some importance.
Yeah. So that's why that is called calculasia. Even everything is fine, but we are not. We don't dare to give the dose. So I think thank you all. We have a nice discussion. And definitely, we discussed all the trials of this this RAS mission. Although it is not newer, but revising the things is very good for all of us. Thank you all. Thank you.
Thank you, boss. Good night, boss.
Thank you,
Thank
sir.
you, sir.
Thank you all.
And thank you all.
Thank you everyone for joining in today.
Good night.
Okay.
Okay.
Good night.
Recording